Hi. Welcome to my fall scene or my spring scene, whichever season you're in. I think it applies either way. We're either getting cold and changing colors in our leaves, or we're getting warm and we're starting to see a lot of new spring plants coming alive again. So we're going to talk a little bit about depression and suicide. I'm going to watch a little video. And I think we're going to start with suicide. I think that that would be the best place to go. Um, Here we go. And I'm going to share my screen with you about suicide. Okay. All right, well, suicide is a permanent solution to a temporary problem. Unfortunately, this seems to be a viable option for a lot of people. You have to consider the situation, you have to consider the age, because the problem with suicide is that it trends in the very, very young and the very, very old. And too many people attribute depression and suicide in teenagers to be just normal teenage behavior and or the depression part, and it's not. It's really isn't. Sometimes it presents itself looking like that, but it's definitely not. And in the elders, usually, most people for depression and suicide, they just kind of do an assessment for depression, or they don't do an assessment for depression and suicide because they think that it's something else, because it often will present with somatic features to it, like severe depression causing hallucinations. Um, Namely, like coming into hallucinations, kill yourself, something along those lines. And if that is the case, if you have major depressive disorder with auditory hallucinations and they're threatening, or the voices are telling the patient to kill themselves, you really got to watch out, because they will. They'll listen to the voices inside their head. So that's for the elders. Some of the other language we need to learn is gestures. We see some gestures with the borderline personality. That's where they cut in order to relieve stress or get attention. They're non-lethal injurious acts. Does that mean that the people who are suicidal do not go through gestures? Of course they do. It's kind of like leading up to it. Ideation is where they are thinking about it. They have thoughts about suicide and they see it as an ideal situation. And then they threaten and then they actually attempt. Now we have completed suicides, which are those, obviously they're gone. They have completed their mission. And then copycat suicides, which we had some issues with a local high school not that long ago with copycat suicides. Suicide statistics is the second leading cause of death, 14 to 25-year-olds, and over 65. Things have been going up since the 1950s, with 1.5 million never reported. For every 25 attempts, we have one completion. And it is the 11th leading cause of death in the United States overall. I think that this actually increased because this is for like pre-COVID numbers. So I think it's probably increased since COVID. But they don't have anything up on the CDC site. Risk factors. Now, there are risk factors for suicide. There are risk factors for depression, and they are different. Okay, very different. The biggest one for suicidality is very young, very old. So if they're a very young person and they're a very old person, these are high risk factors. Caucasian, definitely. Male, it's another big one. Substance use, divorced and no religion. So they're missing that sense of belonging. So that's a high risk factor. Psychiatric disorders, sometimes, not all the time. So a comorbidity with schizophrenia, comorbidity with mania, comorbidity with depression. Yeah, okay, but not as important as these others. Professions, high suicide risk for doctors, lawyers, and nurses. And declining physical health also increases the risk for suicide. Biologically, they look at people and they say, if serotonin makes you happy and you have low levels of serotonin, that must mean that you're depressed and you're going to kill yourself. That's just kind of logic. Suicidal behaviors seem to run in families, and I think that we can attribute to that to maladaptive coping. It's a poor coping mechanism used by parents shown to children. Children tend to use that. I like to think that these psychosocial factors are more of a combination than an individual. For Freud, he said that depression is anger turned inward, and that aggression is, or suicidality is aggression turned inward. So first we're angry and then we act out against ourselves, which is what suicide is. That, along with Beck thinking that if we're hopeless and we're grieving our independence, or we're grieving the mental health that we once had, and we're angry and aggressive towards ourselves, that combination makes suicide a viable reality. I've been told there's more than just 3 states now that have a Death with Dignity Act. I think it's like 17, the last count. But Oregon was the first one in 94, which allowed terminal patients to kill themselves with physician assistance. Netherlands, it's been a long time, and Belgium and Switzerland since 1918. So self-determination has been a long time in different countries. The United States is pretty much lacking at 17, only 17 of the 50 states. So when we're assessing suicide, we want to talk to people. I know we've gone through the steps and what you ask them and where you ask them, but you need to consider other things. Are they giving you verbal cues? That's going to tell you how close they are. Are they giving you nonverbal cues? If they say, yeah, I have a plan, I'm going to kill myself, but they don't have a gun, that's less lethal than, yeah, I'm going to kill myself, I'm going to hang myself, and I bought the rope the other day. So that's more of a lethal method. Got to look at all the risk factors that we just kind of went through, and then we're going to assess for the stages of suicide. Now, the verbal cues can be covert or overt. Covert being under the covers or hidden. So they say things like, things just won't work out, or I won't be a problem much longer, or I'm going to give my body to science. So all these things are just kind of, they're not really being obvious, but they are thinking about suicide. Versus the overt statements or obvious statements. I can't take it anymore. I wish I were dead. I'd be better off. Everybody would be better off if I died. Those are pretty obvious statements that they're thinking of suicide. When you're looking at the lethality, you definitely have to look at access. So gun, as I said previously, if they say they're going to shoot themselves and they don't have a gun, that's going to be a whole lot less lethal than I'm going to hang myself and I bought the rope. So, but it's still considered a highly lethal method if they have access. Whereas risk cutting is more of a gesture. Leaving the gas on their house is more of a gesture. Non-prescription drugs, aspirin, Tylenol, excluding aspirin and Tylenol, non-prescriptive drugs is more of a gesture. And then tranquilizers like Valium, things that just will put you to sleep, but you still will wake up from. That's more of a gesture versus actual, carbon monoxide poisoning, where you get in your car in the garage and you shut everything up and put your tailpipe into your car, or putting rocks in your pockets and jumping in the water, or tying your foot to a brick and jumping in the river, things like that. You can purposefully drown yourself. Car crashes. I always look at if they've been in a car crash and they said, yeah, I was trying to kill myself. I look if they went to hit a tree or if they went to hit a pole, because if they went to hit a pole, it's more of a gesture because the pole will break. Versus if they went to hit a tree, it more was an actual attempt because the tree's not going to move. So, there's gradients on lethality, but gun definitely is the most lethal. The stages of suicide, first people think about it. They're hurting and their thinking is very cloudy. They just, they're afraid of dying. They're afraid of suicide, but they're really ambivalent to whether or not they're going to do it. They're just thinking about it. So when they get to stage 2, this is when they decided that it's okay, that this is what they're going to do. It's really the only option that's out there. And they usually brighten, they smile, they start giving away their things. And that is a clear sign that they have decided to go ahead and do suicide. And then they attempt it. So suicide's the best choice for everybody, they say. Usually the attempt, though, will go about 2 to 3 days where they actually get ready to do the attempt. If they still don't want to die, they may choose a lesser method to, like cutting a little deeper than they probably should, but not deep enough to kill themselves, just to get that help that they need. Yeah. Okay. Nursing diagnoses for suicide. So if you're looking at nursing diagnoses or nursing problems in clinical, we're going to look at potential for suicide or risk for suicide. That's always a risk for ineffective coping, hopelessness, powerlessness, self-esteem disturbances. That's a good one, or spiritual distress. And then you have to look at yourself and you have to decide, can you take care of this type of patient? Can you take care of this kind of person? Somebody who is sad, somebody who is wanting to end their own life, or does it make you angry? Does it make you avoid them? Because it's a taboo topic, basically. Someone who's trying to commit suicide it's just ingrained in our society, I think, is that it's just not something that people want to talk about. Decide who you are as a nurse, go with it. There are support groups. Crisis is temporary. Pain can be survived. This is a wonderful support group here. Coleman actually has a hotline that is manned 24 hours a day. So when we go there on HPS Day, you be sure to ask about that so they can tell you or give you the number, and you could have that in your pocket of things that you could share with patients if you need to. St. Rita's actually has a no harm contract. They haven't used it in quite a while, but they do have one that they can say, the patient says, I'm not going to kill myself or harm myself in any way while I'm here, and they sign and the nurse signs. The thing with this is that when people sign a contract, they tend to want to fulfill that contract. That signature is very powerful. Some other things we do up at St. Rita's is that the rooms are already secure. The windows are, break-proof glass. We don't give them real silverware. Not going to happen. We take away all their cords and strings, no belts, no sharps. Even the razors that they use are safety razors. If they are really, really depressed, you may need to have a sitter. You may have to be with them one-on-one. So that they don't attempt to do something to themselves, like beat their head against the wall or something like that. Right now they do it all the time, is this every 15-minute checks. You see a nurse, you see the tech, she's got a little handheld device. She's going around and she's checking all the patients. That's every 15 minutes. They do rounds with the rover. You'll see who has the rover, who's doing the rover, who's doing rounds. That's what they're talking about, is checking on them every 15 minutes. That therapeutic relationship is very important with your suicidal patient, because if they have a lack of belonging, at least they can be part of the milieu up there, and they can depend on staff, not individual people, but on staff to be consistent in taking care of them. Survivors of suicide, there is a support group for that. Coleman offers a support group for that. They have a lot of guilt, a lot of shame. And it's another thing that we really need to know that other people are experiencing. Okay, so we got a patient. He's hospitalized with depression, suicidal ideation. He's tried to kill himself before. And for the first 2 days, he rarely ate anything and stayed in his room. And by the 4th day, he's much happier, eating meals, he's out and about, has a bright affect. What should you consider? He's only been on his meds for 4 days. So which one? Now, if you picked B, you are correct. He may have decided to commit suicide. Okay. That is suicide. Okay. Screen sharing is stopped as the shared window is closed. Okay, good. So now we're gonna watch our video that we had part of from this morning. And I'm going to restart the whole thing. Okay, and here we go. Do, do, do.
My name is Brad Hagan. I'm currently an associate professor at the University of Lethbridge in their School of Health Sciences.
Yeah.
The way we set up the educational videotape series is the most likely scenarios that students would have to encounter. First thing we want to show students is
I have no idea what's happening here. Let me get rid of this. Stop that share. We're gonna try this again. Okay, I'm gonna go here. I'm gonna go here, I'm gonna hit that. I'm gonna do this. Oh, here we go. Okay, start. And I'm gonna go back here. Share my screen. Yay.
Morning, Claire. It's
And
Pat.
boy,
I was here yesterday. Mind if I come in? It's kind of dark in here. Mind if I open the curtains a bit? How would you feel if I let in a bit more light? It's really kind of a nice day out there. Not too much. I noticed you didn't have any breakfast. I was gonna wake you up earlier, but I thought I'd let you sleep. Do you feel like eating anything now? It's real important to eat. Sometimes not eating can make you feel worse. There's cereal and stuff that we can make real quick if you'd like. Would that be all right?
No. My stomach's really off right now. Maybe later.
Sure, you just let us know when you want something to eat and I can help you find it. Is your stomach okay? Is there anything I can do for your stomach? Looks like you've got a couple of nice cards here on your table. Who'd you get those from, your husband?
Yeah. My kids.
That must feel great, getting such colorful cards from your kids. How old are your kids?
3 and 7.
Boy, those are exciting ages. You must sure miss them here in the hospital.
I miss them terribly. It's like having my heart cut out. Too bad they have me as a mother. I know how hard all this is on them. You're better off without me. Better off with me dead.
I don't think that's true. From your cards, it's obvious that your family really loves you and needs you. You have to remember that your depression is still quite strong and your medications haven't had time to work yet. That's why you have bad thoughts about things and your family. You have to try and be patient, Claire.
They'd be better off without me. I should know. My husband can find someone else. Someone, someone prettier, younger, more loving, more full of life. She can be their mother. I've had my chance and I blew it. They all deserve better than me. I'm just too tired. I don't give a shit anymore.
Claire, you have to remember that you're not going to feel like this all of the time. I'm sure your family loves you very much, and I'm sure they don't want another mother. You're their mother, Claire, and they want you. You have to try and stop this negative thinking.
I'm just too tired of crying. Feeling this way of everything. I just want it to end. I wish it would all end. I wish I would end.
Listen, how about if we go for a nice walk up to the hospital gift shop? It might help to take your mind off some of these things.
I just want to be left alone.
Okay. I'll come back at lunch. Maybe you'd like something to eat then. Morning, Claire. It's Pat. Mind if I come in? Looks like you're having a hard time even thinking about getting up this morning. Do you mind if I open the curtain a bit? I'll make sure it doesn't get in your face. Is that okay? Your face says you're having a rough time of things this morning. Can you tell me some of what's going on?
Just gonna stare at me?
I don't mean to stare. I apologize if I made you feel uncomfortable. I was just hoping we could talk about some of the things that were going on for you today.
Same shit. I don't want to bore you with it.
I don't bore easily. Try me.
I'm just so tired all the time.
What are you most tired of?
Oh, just the same old crap. Feeling like my family and friends were better off without me.
So it's that same feeling of being a burden to your husband and kids. Of just feeling like you're in the way?
Yeah.
That must feel pretty painful.
Just- I know they'd be better off without me. Just wish they could find a better mother, better wife. Just let them get on with their lives. They can't do that with me in the way.
Sounds like you want your family to find happiness, even though you've given up on ever being happy yourself.
Yeah.
Well, despite all the pain you're feeling, I think it's pretty admirable that you can still have a lot of love for your family, to still want the best for them.
I guess.
Well, I think it's impressive. A lot of people with depression like you don't care about anything anymore, not even their families. So I admire that in you. You obviously care for your family a lot. It's just that you feel like a burden to them right now. Is that right? When I walked in here a few minutes ago, it looked like you weren't doing very well. And I was just wondering, overall, how you're doing. On a scale from 0 to 10, where 10 is where you felt like your old self before your depression, and 0 is the worst you've ever felt, like when you made your suicide attempt last week. Where would you rate yourself this morning? Well, even though that's pretty bad pain, it's still sort of impressive. That's about a 20 or 30% improvement in just 1 week. So even though I can see you're obviously still feeling a lot of despair and sadness, things are a little bit different than when you first came in after your suicide attempt. What do you think is different about now than when you first came in last week?
I don't know.
I know it's hard to pinpoint it, but something's obviously happened in the last few days that's brought you up from a 0 to a 2 or a 3. What do you think is different now that's making you feel a little less worthless and a little less suicidal?
Uh, I guess I'm not feeling so overwhelmed.
So there's a little less pressure on you here. You get a bit of a breather from some of the things that are stressing you out.
Just a bit less stress, I guess.
So you say it helps a little tiny bit being away from some of the stress you're under. Of all the stress you're trying to deal with, which one are you in most need of getting a break from?
the kids. They're so tired. I can't look after them. But see, that's just the thing. And that's why I'm such a lousy mother. Because I should be able to look after them. They're really good kids. I'm just so washed out and depressed. And I look after them. And then my husband has to do all the work. And he's tired from his work. He tries to understand. He tries to be patient. And they can't understand. How could they understand? There's nothing to understand. I'm just in the way, that's all. And that's what it would be better off if I just got out of the way and they could get on with their lives.
So even though you get a break from looking after your young children while you're here in the hospital, and you say that helps a little bit, still sounds like there's a lot of stress about you not being able to be the mother you think you ought to be.
Yes. Why did my husband have to find me? Why couldn't he have just let me die in peace? Why do I have to go through this? Why can't it just be all over?
Claire, I'd like to go back a moment to where you stated you were a 2 or a 3 on the scale that we talked about. A lot of people with depression like yours find that they get better very slowly, almost like taking a whole bunch of little baby steps. You've already identified that being away from some of your stress helps a little bit. I'd like you to think about anything that you think might help you to get from a 2 or a 3 to a definite 3. Just a little baby step. When was the last time you felt yourself at a definite 3?
I don't know.
Doesn't have to be recently. Just think of any time that you felt just a tiny bit better.
Yes, when I go to group.
Yeah? What is it about group that makes you feel more like a definite 3?
No. I don't feel so alone. I don't feel so crazy. Like there are other people with problems like me. With depression.
So it really helps to think that there are other people with the same problems as you, people with the same struggles that you have. When is your next group?
Afternoon.
Well, I have a bit of homework for you. What I'd like you to do is after group today, Write down the number that you think you'd rate yourself at from 0 to 10. And then write down what you think it was about the group that made you feel the way you rated yourself. Then I'd like to talk about what you wrote down before I go today at about 2 p.m. Do we have a deal?
I guess so. Who's got it done though? I don't see how it will help.
Well, I appreciate you being a good sport and playing along with me. I have to go check on some other patients right now. But I'd like to thank you for having the courage to talk with me about some of these things. Is there anything else I can do for you right now? Okay. Talk to you later.
Okay. Let me shut this off.
In these two scenarios, would a lot of student nurses
Nope. Okay, so that was the full video. And you can see how slowly you need to move with someone who's depressed. So let us go and we'll talk about depression now. Oh, looks like I don't have it up yet. I need to get it though. Go back to modules and bring up depression. Okay. I know we talked about this earlier, so it's going to be kind of repetitious, but just in case you didn't hear everything earlier, we'll go with this. Okay. So now I'm going to, not this one. Share my screen, good. And we are talking about mood disorders now. Yeah, there we go. So we spoke about depression being on this side: major depressive disorder, situational depression, dysthymia, and seasonal affective disorder. These are the things that we are concerned about when we're talking about depression. Situational, major, dysthymia, and SAD usually can be medicated. Some people don't want to be medicated, but you can be for each and every one of these. We spoke about Winnie the Pooh with Eeyore having dysthymia. 70% incidence or prevalence rate, depression more in women than in men. Again, depression is one of those for the very young and the very old. And most people think most teenagers are depressed, but really, that's not true depression. So depression usually onsets in the mid-30s if it's going to be major depressive disorder. And there's some statistics there if you're interested in statistics. We spoke about Caucasians being more at risk for depression versus other ethnicities or other races that actually have a shared common past, whereas Caucasians don't have that kind of a traumatic past. Okay. Neurobiologically, it's serotonin. They're under activation or under use, or the receptor sites, there's not enough receptor sites for it. It could be because of displaced sleep. It could be because of this. Don't worry about that. I still don't remember what it is, but increases in cortisol, which we see in diabetes, we see it in Cushing's, Addison's kind of thing, and some genetics. Psychoanalytic depression related to loss would be situational. Depression, according to Beck, is how we think about things, and then that learned behaviors, that learned lack of control. We talk about that in class extensively. Life stressors causing mood disorders, not really. Personality characteristics, and a little bit of nature, a little bit of nurture, it's always a possibility. But remember that bipolar and unipolar or major depressive disorders are considered mood disorders. Okay. Other diagnoses that look like depression, stroke, diabetes, sleep apnea, certain medications can cause it. Cancer, vitamin deficiencies. I know we talked about this a little bit. Here's your DSM-4 criteria, DSM-5 criteria: change in previous functioning. Symptoms cause impairment in functioning, depressed mood, and hedonism, weight loss, suicidal thoughts or attempts. Now, remember, when I talked about suicide, it did not say that they had to be depressed. Okay, but to be classified as depressed, you may or may not have a suicidal thought or attempt. Insomnia, hypersomnia, psychomotor agitation or psychomotor retardation, increased concentration, decreased concentration, indecisiveness, energy, I'm sorry, not increased, just decreased concentration, indecisiveness, energy or lack of energy, feelings of worthlessness and guilt. Here's some nursing diagnoses for depression that you can look at. We want to do our regular assessment in depression, but we really want to focus on how well they're taking care of themselves and what kind of roles and relationships they have. And then you have to look at yourself. How do you understand depression? Is it something that you think somebody can snap out of? Because that is not true. Or is it a systematic illness with complex interactions of causes? And that is a true statement. So acutely, they come in, we put them on medications. They're at danger of suicide probably 2 weeks after beginning an SSRI because they have the energy, but not the actionable or not the action to feel better, but they have the energy and the action to kill themselves. So we have to be very cautious with that. We need to keep them on the medication, and it's going to be lifelong. Sometimes they need other medications. Sometimes they need electroconvulsive therapy, some help with physical needs. We need to keep a calm milieu. We can do cognitive behavioral therapy that might help hopelessness, helplessness, but not as much as support groups. So an easy way to get started with somebody who's depressed is make an observation about them. Use very simple words. Allow them time to talk, and I told you that can take up to an hour. Listen for those overt, covert messages and suicide plans, and don't tell them, oh, everything will be okay. That's a platitude, so don't say things like that. ECT, electroconvulsive therapy, they used it a long time ago. They've refined it over time. It's kind of like hitting that Control-Alt-Delete on the computer. It's the action of ECT is kind of like resetting the brain chemistry. It's really good. It does require cycles or course of treatments over time, and depending on the individual and how they react. It's used for schizophrenia, major depressive disorder, resistant and mania, and sometimes antisocial mood, but it just depends, not antisocial personality. It just depends on if the person's willing and ready to do that. Nursing care, pre-op, post-op, sometimes even intra-op, sometimes they need oxygen, supplemental oxygen, because they might give a paralytic and not a complete paralytic, but a half paralytic, so that the respiratory rate is depressed as such that you want to give them oxygen so that they don't have brain damage from anoxia. So that's kind of an intra-op thing. But that's dependent on if they're going to do that or not. Okay. Side effects, headache, memory loss, confusion, anesthesia effects, and other risks. You have to realize that if somebody has a brain tumor or if they had cardiac problems, taking seizure medications, chances are we're not going to use ECT, but there's no absolutes. The meds that are out there, think about the meds that are out there. First line is usually SSRIs, serotonin reuptake inhibitors, selective serotonin reuptake inhibitors. You need to know one for the quiz. I don't care which one you pick, but I'm going to have to go through each one individually, each quiz, and make sure that that is what it is. And no, it is not Wellbutrin. Don't pick that one, okay? Pick something a little more traditional. Second line, we can give tricyclics, MAOs, we can do ECT, we have the degludec methylate. Here's just the receptors showing it. The MAOs, like I said, I don't like these. They're used infrequently, mainly because of their complications and their strict diet. Keeps the MAO enzyme from destroying norepinephrine, serotonin, and dopamine, increasing the neurotransmitters. Tricyclics, tofranil, Elavil, when you see most commonly, Pamelor in nursing homes, nortriptyline. The second oldest class, they use a lot for diabetic neuropathy also. They block reuptake for norepinephrine and serotonin. The SSRIs, here's your laundry list. Pick one. I don't care which one you put. Prozac, Paxil, Zoloft, Celexa, Lexapro, or Luvox. They block the reuptake of serotonin at the synapse to increase serotonin levels. The newer atypicals, they include the SNRIs, the NRIs, and there's just straight atypicals, like Wellbutrin. The atypicals, the newer ones, there's your SNRIs, Cymbalta, Effexor, and Pristiq, Remeron, and Wellbutrin are just traditional atypicals, and Desiril is a tetracyclic, but these are all kind of grouped together because they're not SSRIs and they're not tricyclics and they're not MAOs. So they all fall in this atypical category. The side effects of antidepressants, all of those except the SSRIs are anticholinergic, alpha adrenergic from the norepinephrine. You have depressed CNS, sexual effects, including impotence and weight gain. Side effects of the SSRIs include insomnia and headaches, agitation, that woman who killed her husband, GI, sexual problems, weight changes. I think Luvox is the only one that is weight neutral. Frequent stools, anxiety, akathisia. Serotonin discontinuation syndrome is where they feel good. They immediately stop the serotonin or the SSRI and they feel like they have the flu. You can get toxic on your antidepressants. You can overdose and it'll kill you. You can have seizures. Tricyclics cause all sorts of heart problems. You can, if you're taking SSRIs and you really are a bipolar and not a unipolar, it can cause mania to erupt. You can have serotonin syndrome, serotonin discontinuation syndrome, and the MAOIs, if you eat the wrong thing, hypertensive crisis. Serotonin syndrome is from an overactivation of the central serotonin receptors. So basically, serotonin syndrome, irritability, rigidity, sometimes you can have shock, pain, abdominal pain, tachycardia. These guys, this is the woman who killed her husband. She was experiencing delirium and she put it all on serotonin syndrome. Treat the symptoms and stop the anti-seizure or antidepressant drug. The big thing is you got to be careful as you slowly take them off the antidepressant drug. You don't want to immediately stop it because then they'll throw into serotonin discontinuation syndrome, which is less lethal, but still is unpleasant. Hypertensive crisis comes with the MAOs. When you eat the wrong food, you can treat it with rididine to bring that down, but oftentimes it's just better not even to use the MAOs. And here's your dietary restrictions. This is like my This is everything in my, my cabinet at home. So I don't think I would do well on MAOs. Other things, you can't have epinephrine, any antihypertensives, anything with cold, cough and cold with pseudoephedrine. Not really supposed to use Visperion, Meperidine, or SSRIs. All those things can also cause a hypertensive crisis. We have tyramine foods, avoid tyramine foods, which are all those good foods like Chinese and whatnot. We want to avoid St. John's wort. Avoid the cold and cough and allergy medications, other antidepressants. Overall, call the doctor if your blood pressure is going up. So you're going to have to check your blood pressure frequently during the day if you're taking an MAO. Antidepressants are not addictive, but you do feel better on them because you feel normal. It doesn't make you high. If it does have the weight gain side effect or the impotence or whatnot side effects, that's going to go away. It's just going to take time, and you got to give it up to 6 weeks to become effective for SSRIs. Most of the others will show up within probably about 7 days, but those SSRIs, top of the class, it's going to take, 4 to 6 weeks for those to get going real good. Responses, like I said, in week 1, decrease anxiety, week 1 to 3, improve sleep, improve concentration. Week 2 to 4, they start to feel better, less hopeless, and not wanting to kill themselves. But you have between week 2 and week 4 on the medications where they could commit suicide. So be careful with that. Here's your blue brain and your recovered brain. I think that is everything. Yep, that's everything. Okay, so that's everything for depression and suicide. And I think I went over everything with the quiz. With depression, make sure you understand how it would present itself. Oh, I did forget to mention depression over 6 months is considered pathologic. So if you're still grieving a loss over 6 months, you truly are, it's considered to be depressed. So that needed to be said. You might need it somewhere. But anyway, I hope this helps. I hope you do okay with the quiz, and I will see some of you Wednesday, my last week 5 of the middle 5 weeks. Come prepared to talk about your self-help group, and then the rest of you I'll see next Monday. Okay.